Thank you, Beth. Good morning, everyone. I'm very grateful for this opportunity to talk about imaging. I think 7 years in a row. I'm really happy about this. I also understand it's the last talk before lunch, so it's going to be 10 minutes, promise, with focus on the essential insight for cath lab stuff. Yeah. So I'll quickly mention just 2 trials because Dr. Sharma covered all imaging trials already, but I want to go a little bit deeper inside and to show you what it means to have a clinical trial in your cath lab. Then we're going to compare use of imaging to real life PCI, and then we're going to look at some barriers to widespread imaging adoption and how new technology and education can actually help us to overcome those barriers. Just a quick reminder that we still have 2 major imaging modalities. This is OCT and IVUS. However, some new things coming up, combining 2 of them in one catheter to make it even more complicated. OCT and IVUS, both high-resolution imaging modalities. You can get high-resolution images of lesion, vessel wall with both of them, but OCT has a greater resolution and a little bit faster frame rate. And then, but IVUS can look deeper inside the vessel. Tissue penetration is up to 10 millimeters. And we don't need to clear blood from the vessel to have IVUS image. Dr. Sharma already described this trial, Renovate Complex PCI, that was done in Korea, and a lot of very complicated lesions were enrolled in this trial. What I wanted to show you that I think it's a unique trial because the choice of imaging was left to the operator. There was no specified imaging use. And as a result, 77% of IVUS was used for image guidance and 23% OCT, all operator decision. So the outcomes, absolutely amazing results, almost 50%, 40% decrease in target vessel failure. This is cardiac death. This is MI, target lesion revascularization. Each individual endpoint was also significant. But I think a very interesting result was when in a sub-analysis, OCT was compared to IVUS to see which one is better. Actually, it didn't matter which imaging was used. Both OCT and IVUS provided better results and better outcomes compared to angiography-guided PCI, which suggests that probably it doesn't matter which imaging you use. We just need to use it and properly according to the protocol. Another interesting observation from this trial that stent optimization was achieved in 56 of IVUS cases and 66 of OCT cases. So we don't even know how these curves would look if we had 100%, maybe even better. And this is a European trial, October trial. Very complex bifurcation lesions were enrolled in this trial. Only OCT was used here. I wanted to show you what cath lab personnel had to run this trial. So this is the protocol, not the complete protocol, just the summary. Each step, each OCT, before stenting, after each additional rewiring was described in every detail, how to size the stent, how to analyze images, how to decide if calcium was modified sufficiently enough, if there are cracks in calcium. Everything was described in the protocol. Not only that, there was extensive training and education for each site, almost real feedback time from the core lab and between core lab and the sites. And there was, I think, weekly case review meetings. So all this education and protocol development and communication with experts almost real time, I think this is a very important contributor to success of this trial. So what's going on in real life when we don't have a core lab and we don't even have a lot of labs don't have imaging fellows? I think it's a luxury this time. So this study was done 2 years ago, but it shows that imaging use in real life was 16.6%. Dr. Sharma mentioned today 22%, I think coming to 28%. This is the use of imaging in real life PCI. This is the table shows that main predictors of imaging use was actually not lesion characteristic of patient characteristics except to left main. Left main, of course, this is very complex lesion. Everyone wants to have imaging. But look at the second and third factor. That was performing physician, performing hospital. So this is still mostly a preference of physicians. Also, a lot of other factors going into this. Substantial variation was observed between hospitals' physicians. You can see on the right side that a variation from 1% in low volume hospitals to more than 60% in high volume hospitals, high volume, high use physicians. So what are the main barriers? There's a lot of studies actually published on what is preventing imaging from widespread adoption in all cases. I wanted to share with you this feedback from non-physician team members. These are actually last year's CRT Symposium Nurses Technologists. And these are 5 main concerns named regarding imaging: increased procedure time, procedural cost, difficulties in image interpretation and understanding that software, and also insufficient training. So the first 2 concern, of course, imaging as procedure time and money. So I wanted to show you another sub-study of this amazing Renovate complex PCI trial. So they compare cost imaging arm and angiography arm. Of course, imaging was associated with greater cost at the beginning, immediate cost. It's the catheter cost and time. But then when the costs were projected for the lifetime of patient for 10 years in this study, these curves actually flipped. And we can see that angiography guided PCI became more expensive because the angiography patients from this arm required more medical care than imaging guided arms. Dr. Kinney already showed AI features in OCT and IVUS. This is AI for OCT, which automatically detects calcium. We can see calcium now in longitudinal, in cross-sectional area. We will see it on angiography. And we're going to find calcium which we don't see on angio because angiography systematically underestimates calcium. OCT already has automatic detection of lumen, size, stent malposition, stent expansion. So taken together with all these already existing features, I think this software is pretty close to a fully automated software. We just need probably lipid detection for this. IVUS is also, IVUS introduced also AI now. We don't need to look for that minimal area and spend a couple extra minutes. It's already automatically detected. Minimum lumen area and plaque burden at references, so we can quickly find healthy landing zones and to know where to put stent. These are great improvements, and of course, time will be saved. We use this and we learn this. In Mount Sinai Lab here, we pioneered educational mobile applications. Dr. Kinney already showed them. We have a booth outside for all the apps, 2 of them imaging applications. Octade was released in 2018. Is a very popular software app. If you want to learn OCT, it has pretty much everything. You need to run a case, how to prepare a catheter, how to understand images before stenting, how to assess post-stent results, and we have not only screenshots or stills, we have videos, we have quizzes, we have real life cases. I think it was updated last year with more cases to show even more scenarios of using Octade. And I would say it was released just last year because we kept getting feedback from people why you have only OCT. It has similar structure, and you're gonna learn a lot. If you go through quizzes, through images, we talk more about catheter preparation because there is more IVUS systems available than OCT, and some of them require different approach in catheter preparation. So please download those applications and check them. So I wanted to conclude with this, with statements that using imaging, intravascular imaging for PCI guidance saves lives. We saw it in clinical trials. I think we don't need more convincing. And of course, there is a lot of more work has to be done to use new technology education to overcome those barriers toward widespread image use and to improve this, increase those numbers. Thank you very much for your attention.